deeply connected to the future of our community and our world. We all say they know the healthcare system of a country is always related to maternal and child health. The theme, safe birth, strong future, reimagining maternal and child health in LMC, it reminds us to every mother and every child deserve a chance not just to survive, but to strive. Together, through dialogue, innovation, and collective action, we can transform systems, inspire change, and ensure that no one, no woman, or children is left behind. I'm excited to the rich discussion ahead and look forward to the impact this dialogue series will create. Thank you for the invitation and for your commitment to building stronger future for all. Thank you.
Thank you so
Thank you
much,
very
Doctor,
much, Prof.
for that warm and inspiring message. Your words truly set the tone for the important conversations we are about to have. Now, without further delay, I am pleased to hand over to our moderator for today's session, Dr. Bisola Olubiyi. Dr. Bisola, over to you.
Thank you so much. Good afternoon, good evening, or good morning, everyone, wherever you're joining us from. Bisola Olubiyi once again, and we are glad to have you for the very first installment of this dialogue series talking about maternal and child health under the auspices of FIRAT. So we'll just dive, right in. With the increasing availability of research findings, interventions, and policy updates, there's that huge, crucial, and very important crucial gap in knowledge translation to practice. And one of the reasons would be because of the gap between the practitioners and the researchers and the public health, the policymakers. There's that gap, as it were. So, like has been earlier said, one of the aims of this dialogue series is to try to, bridge this gap between everyone. Sorry, I hope everyone can hear and see me well. Just checking.
Yeah, we can hear you.
Yes, we can hear you.
But can you see me, please?
Yes, we can
Yes.
see you.
Okay. All right. Awesome. Thank you. Okay, so this series, like I was saying, aims to bridge the gap by fostering a platform for discussing and disseminating evidence-based solutions to advance maternal and child health outcomes. Recently the World Health Day was celebrated on April 7th, and the theme was Healthy Beginnings, Hopeful Futures, which is basically trying to focus everyone's attention, both practitioners, policymakers, and researchers, on maternal and child health so that we can drive down mortality, both for mothers and their children. Now, maternal mortality is defined as death of a woman while pregnant or within 42 days of termination of pregnancy from any cause whatsoever related to or aggravated by pregnancy or its management, but not from incidental or accidental causes. There have been so many reasons why this happened: health system failures, poor quality of care, shortages of essential, medical supplies, inadequately trained healthcare personnel, poor accountability. The list is endless. So these are things that we'll be discussing and, picking out salient points that can be applied, areas to go for research and all of that. So I will just go right in to introduce our very first guest today. He is Dr. Salau Ayotunde Hafiz. He's on the call right now. He obtained his MBBS at the University of Ilorin, and he has a master's degree in disaster risk management from Ahmadu Bello University in Zaria. He's a fellow of the West African College of Surgeons in Obstetrics and Gynecology, and he worked with Kwara State Specialist Hospital, Sobi, where he was HOD until January this year before moving to Dr. Aisha Buhari Mother and Child Hospital, Eyenkorin in Ilorin, where he is currently the HOD. Dr. Salau, can you please just say hello? Dr. Salau, can you say hello, please? Okay, maybe it's getting the audio ready. I will just go ahead to introduce our second speaker. Is Mr. Pradeep Lamsal. He's a trained pharmacist from Nepal. He has a certificate in global health delivery from Harvard University and European master's degree in drug and alcohol studies, and is currently engaged in a doctoral degree at the University of Geneva. He has over 2 decades of experience as a technical advisor, a policy expert, and also he works at the Helping Hands Hospital in community hospital in Kathmandu.
Hello, am I audible?
Yes, you are.
Good morning, good afternoon, good evening. I'm honored to be here to discuss about the maternal and child health mortality in this prestigious forum. I just like
Thank
to
you.
say welcome to all in the platform. We will discuss forward to have a fruitful discussion toward developing the strategy and sharing the knowledge regarding maternal and neonatal mortality in limited resource setting. Thank you.
Thank you so much. It's great to have you. We are very excited for the conversation ahead. Dr. Salau, can you please say hello, a few words?
Hello, good afternoon. Can you hear me now?
Yes, we can. Good
Hello, am I
afternoon.
audible?
Yes, you are.
All
Good
right, good afternoon,
afternoon.
everyone. It's I'm honored to be here to be sharing experience with the intellectuals on this platform.
Thank you very much. So we'll just start from Dr. Salau. Can you maybe just give us a few words about your experience and your journey so far with maternal and child health in just about a minute?
Okay. Good morning, good afternoon, good evening, depending on where you're listening to me from. Um, Maternal mortality, maternal health, and child health is a very important aspect of medicine. And as an obstetrician, it forms a major part of my day-to-day activities. And the death of a woman, especially in pregnancy or during childbirth, is usually very, very uh, catastrophic, to put it mildly, because it's usually something that's very painful to both the family and to the healthcare providers. So, in terms of my experience with working in maternal and child health, the problems I think in Africa is peculiar. We we have a lot of our women being ignorant of the things that they should do, and by the time that we're having contact with the health facility, usually they usually come in with complications, which many times is usually very difficult to handle. But we've been doing advocacy, and we hope that with time we'll get it right. Thank you.
Thank you very much. Mr. Pradeep, can you please tell us a bit of your journey with maternal and child health? I know you do mostly related to essential commodities in terms of essential medicines. Can you tell us a bit of your journey, your experience. We can't hear you, Mr. Pradeep.
Hello. Am I audible?
Yes, we can hear you now.
Thank you. Since last 2 decades, I have been working as a community health worker in one of the non-governmental organization in capital city of the country, Nepal, and we do have the 7 satellite clinic in the different territory of the country, which is hard to reach, which has been serving to the hard to reach people. Uh, Technically, I have been trained as a pharmacist, but I encountered in various part of the work-related activity to save the life of mother and child during the uh, pregnancy, and I have. Walked through those situation where basic health commodities, access to the quality health service, access to the skilled health professionals during the pregnancy period is quite scary in limited resource setting like Nepal. These these instances had led me to work toward the access to basic health commodities as well as the basic quality health service in limit resource setting through the community participation, overarching the policy reform as well as the uh, mm, applying the leadership management and governance approach to the local government bodies to ensure the availability of quality health service, quality commodities, and the um, quality as well as the skilled health professional during the time of their pregnancy period as well as the throughout their life. These are the some of insights where I walk through toward the saving lives of mother and child in limit resource setting. Thank you.
Thank you very much. Um, so we'll just go to the first question. And I want to just say this to the audience as you're listening along. If you have any questions, please just note them down. Towards the end of the webinar, we'll be taking questions, so you can just note them down. So, Dr. Salau, I understand, like we had defined earlier in the definition of maternal mortality. So, just for our knowledge and education, would you educate us about the leading causes of maternal mortality globally, and also as it's peculiar to our own climate in Africa, and how do these really differ in terms of the causes of maternal mortality?
Hello, can you hear me?
Yes, we can hear you.
Am I audible now?
Yes, you
Okay,
are.
I didn't get the last part of your question, but from where I got it from, um, we wanted to talk about the leading causes of maternal mortality.
Yes, and if this differ in the
Hello?
African context. Yes, the leading causes of maternal mortality, and if these are different in the context of Africa and other LMICs compared with, the West and the global North.
All right. Thank you so much. So, like you rightly defined maternal mortality, which is the death of a woman during pregnancy, childbirth, or within 42 days of termination of pregnancy, irrespective of the duration or the site of such pregnancy, resulting from complication arising from the pregnancy itself, or interventions that are made to manage those complications, but not from incidental or accidental causes. So the leading causes of maternal mortality generally globally are uniform to some extent. Obstetric hemorrhage is still the major, the commonest cause of maternal mortality in most climes. And this will include bleeding before delivery, and more commonly, bleeding after delivery. Then we have hypertensive disorders of pregnancy and its complications. We have infections, then complications of dystocia, that's obstructed labor. Then the fifth one is the complications arising from abortion and its management. So before now, in our climb, in low and middle income countries, hemorrhage appeared to be the leading cause of maternal death in this climb. But in recent time, we've seen a gradual shift towards the hypertensive disorders of pregnancy, especially here in Nigeria. For active management of labor seem to have curtailed the occurrence of hemorrhage as a leading cause of maternal mortality. Though this is not or across board, because most of the statistics we have are usually based on the hospital-based deliveries. But generally, in the Western climes, before now, the leading cause of maternal mortality is usually related to hypertensive disorders of pregnancy. But most people will agree that hemorrhage still play a major role in the occurrence of maternal mortality. In some minority reports, especially in rural communities, infection also appears to be a very, very strong contributor to the occurrence of maternal mortality. So, but on a global scale, these five major causes will account for more than 90% of maternal mortality.
Yes, thank you very much. So from what you described now, it seems like Africa, or should I say LMICs, might have this double burden of causes of maternal mortality, while we still have hypertensive, pregnancy-induced hypertension or hypertensive disorders in pregnancy. And also there's that infection, which is very high, but we might not know the exact statistics because we base statistics generally on the hospital, what you would get from those that go to the hospital, like you said. So I would just say that from everything you'd say, you have discussed, what would be really the biggest barriers to safe deliveries in LMICs, and how can we really begin to overcome these challenges? You've been a practitioner, so what would you say you've seen as the biggest barrier? Because you said if somebody has hypertension in pregnancy, there are medications that can manage. If somebody has infection, there are things that you can do, but there are also things to prevent. In all of these things, in the primary prevention, secondary, tertiary, even the primordial, what are those things that are the biggest barriers to safe deliveries in LMICs? So I will start from Dr. Salau, then we go to Mr. Pradeep.
Okay. All right. Thank you for that very beautiful question. For low and middle income countries, I would say the greatest barrier would be those cultural practices that leads to delays in seeking help most times. From a global perspective, in most high-income countries, they've been shown that the presence of a skilled birth attendant is the most important element in preventing maternal morbidity and mortality. However, we'll notice that in our own environment, a lack of access to these services where they are even available tends to be the major problem. For example, I work in a mother and child hospital. Most of the complications that we get to see do not present early, when we would have been able to intervene and prevent the degree of complications that such women would have presented, with some actually relays when we talk about maternal mortality. And as a form of primary level of delay, is that delay within the community, within the households, that involve things like decision making, uh, and things like that, before they even start going towards the health facilities. So you find out that many times we have some socio-cultural barriers. I give you an example in this part of the world. You see a woman in the hospital, and you want to make a decision to do a cesarean section, for example, and you'll be shocked that the couple cannot even make a decision. They have to revert back to the head of the family or the head of the clan to make such decisions. So even within the community, when the need arises for them to seek for healthcare, they need all these people to be around for them to be able to make decision to even go to the healthcare facility. So I would say that is the major one. The other levels of delay will include lack of access to the health facilities. So even after they made the decision to go to the health facilities, many times, especially in the rural communities, the transportation infrastructure in low and middle income countries is usually very poor, and they usually experience delays in getting into the health facility. And the third level of delay is the ones that occur in the health facility. This is not a major problem in most of our secondary and tertiary health facilities, but the first two levels of delay is a major contributor to why many women will suffer great morbidity or even mortality as a result of pregnancy and childbirth.
Thank you very much for that answer. It's already bringing a lot of thoughts in my mind. But we'll go first to Mr. Pradeep. We would like to understand, particularly based on your own context, especially regarding essential medicines. Like you mentioned that hemorrhage as a leading cause of maternal mortality, it's changing because of oxytocin, but that depends on the availability of oxytocin, of course. So in terms of essential medications like that, and of course other vaccines that women are supposed to take during pregnancy, and medications like IPT, intermittent preventive therapy for malaria, what is your experience with how the barriers that can be in place to keep these medicines from getting to those who need it? And also in humanitarian context, I understand that Nepal has had, some, I would say, some natural occurrences. I believe yesterday was the 10th year anniversary of the devastating earthquake. And this also calls into question how the health system responds, because in as much as there's the disaster, there are women that are pregnant that need access to these things. So we'd just like to learn from your context how what are these barriers?
Thank you. Just on top of the barriers which was presented by our guest speaker, that out-of-pocket expenditure is another major barrier for the in LMICs. I think in Nepal, all the pregnant obstetric care is not covered through the universal health coverage scheme, which leads to the out-of-pocket expenditure to majority of the families, which leads to the lack of institutional delivery. And health-seeking behavior is also one of the barrier which leads to the complication during the pregnancy. And with respect to the availability of essential medicine, especially oxytocin and magnesium sulfate, it is scary. In Nepal, it's while going for the longitudinal survey, the average availability and availability of magnesium sulfate and oxytocin in public health facility is almost 60%, and is quite similar with other lower and middle income countries, because oxytocin, which needs a cold chain method for the storage, and there are the certain disruption in the supply chain system of the country, which leads to the unavailability of those medications throughout the year, which leads to the complication during the pregnancy. And as you already said, that the Nepal is the witness toward the natural disaster and devastating earthquake, where yesterday we celebrated the that event, that scary event. And in these events, the supply chain of those commodities is severely affected, and Nepal is witness on that, where the most of the commodities are out of stock, and the another layer of the supply chain is disrupted at that time, and service is interrupted. So we have to think around the how to manage the stock during those causalities. That's the one another big challenges for the LMICs. And we are also witness toward the political instability and the conflict in Nepal, where the women are mostly sufferer, and they are not able to take the decision toward their antenatal care, which leads to the severe complications. These things I have experienced during my professional journey. Thank you.
Thank you very much. You know, when Dr. Afiz was speaking, I was about to say that this delay to seek care, is it a cultural thing? But from what you said as well, it's your experience in Nepal where people also delay to seek care. Is that right,
Yep.
Mr. Pradeep?
Yeah, you are it's a cultural cultural aspect, cultural perspective, as well as the economic barrier is also one of the major cause for the to seek the health service from the health facility. That's
Interesting.
my experience.
Right. So now we have, from both you and Dr. Hafiz, there's the delay to seek care, there's the economic barrier, and also the transportation challenge. So how do you think, I will still start with Mr. Pradeep, how is there any way that understanding these barriers, what have you been able to put in place in practice to overcome these barriers in your context? And what are the things that are being put in place in terms of policy, maybe health promotion, to reduce the barriers, both economic, cultural, and even maybe in terms of transportation?
Nepal has made significant progress regarding the maternal mortality initiatives, and recently Nepal also implemented one initiative that every pregnant mother, if she needs the transportation service, uh, she will get the transportation service at free of cost from the local government. And if there is a severe complication during the pregnancy, like postpartum hemorrhage or other life-threatening complications, then government of Nepal has implemented one initiative, presidential helicopter initiatives. Under that condition, if the life of the mother is threatened, then local government can ask for the support from government, by the transportation with the helicopter for the pregnant woman to save her life. That makes significant change in Nepal. Mm, if there is the serious complication, and at that point government has rearranged the existing policy without considering the economic consequence, they will provide the helicopter service to the nearest health facility where the surgical interventions, quality surgical interventions are available. That this means that if government wants to create the change regarding the indirect cost associated with the utilization of healthcare facilities, then government can make some incentivizations policies for the family of pregnant women, as well as the skilled attendance, health attendance for the safe delivery. That this experience makes quite progressive initiatives toward saving the life of mother and children in the settings like Nepal.
Thank you very much. That's quite interesting. So, if a woman, for instance, in the local government needs to get to the hospital, she can just go to the local government council and they transport her there free of charge and is readily available. That's interesting because the trends show that
Yeah.
Nepal has committed to. Sorry, you were about to say something.
No, that's how quickly the service is available. That depends upon the uh, transportation infrastructure. If the road is not blacktopped, then it might take some time. Otherwise, they will get the service instantly, and it's 24 hours, 7 days a week, 360 days a year service provided by the government.
Interesting. Thank you very much. Dr. Salau, over to you. So, what are these? We've listed out these barriers. So, now how do we begin to overcome these barriers? In your instance, you mentioned transportation, and I once heard a story of, women in, I think, somewhere in the north, I'm not sure where, north of Nigeria, of course, that the women in the community saw that there were challenges with getting to the hospital, and what they did was everybody contributed to maybe buy, I don't know, a tricycle or something, so that every time one of them needed to get to the hospital for delivery, even in the middle of the night, they can easily access that and go. Otherwise, they would have to maybe use a donkey and travel for hours, and it's a very perilous journey. So, Dr. Salau, what are these strategies that can be put in place to reduce maternal mortality in the light of these identified barriers and things that increase the propensity for the maternal mortality? And if you have seen or implemented a case study of an innovation that you tried out and you saw that it was giving, very good results. Can you please share with us? Dr. Afiz? Oh, I'm not sure.
Can you see him on the
Yes.
screen? Because I cannot see him on the screen.
Yes, he's here.
Okay.
We
Cool.
just need him to unmute. Can you hear us, Dr. Afiz? Okay, maybe he's having some network issues. Dr. Afiz, are you there? Okay, so maybe we'll just engage with Mr. Pradip until Dr. Afiz is able to sort the network issues, I would say. So, Mr. Pradip, in terms of the break, you mentioned that, for instance, oxytocin, there's need to maintain the cold chain. And in terms of humanitarian emergencies, what are the things put in place to preserve these medications? Or even, I don't know if Nepal has electricity issues like some or many LMICs have. So what are the steps or policies that have been implemented to safeguard these essential medicines to get into the women that need it? Mr. Pradip, I think Dr. Salau is back, but after you answer the question, we'll go back to him.
Sure. In humanitarian emergency or other adverse events, Nepal has just started some of the initiatives that these oxytocin can be oxytocin is supplied in parallel with the vaccines. Like the coverage of the vaccination is almost 86% in Nepal, and almost all the remote area they are strategically supplied through the various means of transportation, and these oxytocins are also embedded with that cold chain method along with the vaccines. That one strategy government of Nepal as well as the other non-profit organization along with the bilateral organization, they are implementing such type of initiatives. And some of the areas where electricity is frequently disturbed, in these conditions we are also implementing some initiatives like transporting the oxytocin through the this drone method. In higher center, these commodities are readily stocked, and then if necessary they will transport it to those birthing centers through the drone. If there are the problem with the electricity, or there is a problem with road disruption in the road, that such type of initiatives had implemented particularly in case of Nepal.
Thank you very much, Mr. Pradip.
Welcome.
So, Dr. Salau, I was asking before this slight network issue that you have identified, as well as Mr. Pradip has identified, or he has shared with us some of the challenges that of course they serve as barriers in the fight against maternal mortality. And some of them are delay to seek care, and then delay to make a decision on care while in the hospital. And also you mentioned transportation, that sometimes they make a decision on care. Getting down to the hospital is a challenge. And so I was going to ask that, what are the strategies that you have seen in your practice or that you have implemented to reduce some of these barriers with pregnant women? Or what are some that you are expecting or anticipating that can reduce maternal mortality, given some of these barriers?
All right. Thank you so much for the question. Like I said, one of the major barriers that we have around here is the decision-making process. And I would like to say that the economic barrier, as mentioned earlier, is also part of that primary level of delay that we experience many times. But in terms of practical solutions, Nigeria, for example, is a federating state. So different states have adopted different models in trying to tackle some of these challenges. And I would like to discuss one of the strategies that was adopted by one of the states in Nigeria called Ondo State.
Okay.
Incidentally, when the scheme started, the governor of the state was a medical doctor, so he understood the peculiarity. So he actually started by carrying out a research to try and find out what the root causes of maternal mortality were, and they came out with a form of homegrown solution that was adapted to that locality. And the intervention was such that they had health workers who were community health extension workers that are attached to pregnant women within the communities. So they go to offer the antenatal care to those women within their localities. They identify women that will require care at a higher level, and they were provided with means of transportation, which were basically um, uh, elementary forms of transportation like motorcycles and basic tricycles that can penetrate those communities. So they bring those women into the secondary health facility and the modern child hospitals when they develop complications. And they also provided them with means of communication, both the potential clients and the community health extension workers. And it was a very beautiful scheme because they had a drastic reduction in their maternal mortality figures to the tune of 75%. But again, the economic aspect of it would then come into play, because sustaining such initiative, because it was rendered free of charge to the members of those communities. So many of the neighboring communities from other states actually jumped on it, and over time, the cost of the program went really high up, and it was not sustainable. So the other aspect of whatever initiative, no matter how homegrown it is that we must find a sustainable form of funding. And I'm happy that in Nigeria now we have what we call the Basic Healthcare Provision Fund, in which about 1 to 2% of the consolidated revenue. Hello. Hello.
We can hear you, Doctor.
Okay. Apologies. It's actually raining here, so the network is kind of shaky. So if you can hear me, I'll just go on. So now we have what we call the Basic Healthcare Provision Fund. And as part of this fund, there's provision for the vulnerable
Sorry,
groups,
just
and pregnant
for
women
a bit
and
there.
children under 5 are captured under this initiative. It was recently launched, and the aim of the initiative is to bypass these economic challenges so that indigent mothers um, can go to accredited health facilities to seek for help. I think I will summarize it by saying that the issue of maternal mortality, no matter what intervention we bring, we must tackle basic infrastructural problems that we have in many of the low and middle income countries. Because the issue of transportation is still a major thing. There are some communities that are actually very, very remote. And no matter what interventions we want to take to those communities, gaining access will be a very important part. So, tackling hunger, reducing poverty, infrastructural development, and all of those will also be very important in reducing the scourge of maternal mortality in our environment. Thank you.
Thank you very much, Dr. Salau. I keep going between Dr. Salau and Afiz. I should stick with your name. Apologies. Thank you very much for the example you shared. It just summarizes the crux of this policy dialogue, this expert series that we are having. You mentioned the case study of Ondo State, where because the governor was a medical doctor, he went from research, he translated it to practice, by being the one that, of course, passed the policy that, okay, we have seen that barrier in seeking care is keeping people from going to the hospital at the right time and increasing, maternal mortality from their research. And then they passed policy in terms of, okay, bridging the gap for transportation and also eliminating the economic barrier that is present. But like you said, healthcare financing is a whole lot of, you know, I don't know if I should say a double-headed, I don't know, because many healthcare initiatives in LMICs rely on foreign partners, and we all see what has happened recently, that funding was cut and many people are grappling for, oh, what do we do, what do we do? So that now brings me to this question. A state has done research, they passed policy, and they translated it into practice. Why is this not being implemented in other states? Like you mentioned that these barriers are the same. Also, I want to believe in Kwara states where you practice. And even Mr. Pradip has mentioned the same, that they experience these barriers in Nepal as well. So safe to say, we can say that many LMICs have these barriers. So I want to first of all ask that, why are these things not being implemented in the other states? And how can we bridge that gap continually? Because it took a medical doctor being governor to do that. How can we bridge that gap between the policymakers, and then on one hand, the policymakers, and on the other hand, the practitioners and the researchers? Because you are the ones that know that, okay, we have these problems and these are the potential solutions from research. But the policymakers, they are on the other side, and it's two totally different things. It seems that, I don't know, I would say that the practitioners and the researchers don't have a way of reaching the policymakers, or we don't care. Maybe we just have our heads in just doing the research and getting the results, and we just forget the translational part. So I would just like to have your view on this. How do we bridge the gap between academia and practitioners and the policymakers to make sure that this beautiful research that we do, and we see that, okay, these are the challenges, these are the potential solutions, actually get to them and get translated? So I'll start from Dr. Salau, then we'll go to Mr. Pradip. Dr. Salau, are you there? Okay, Mr. Pradeep, can you please start? Then we go to Dr. Salau later.
That's the interesting area of the discussion. Like I'll just like to
Thank you so much for that question. I hope I'm audible.
Oh, sorry, can you hold on a minute, please? Mr. Pradeep
Hello?
is yes.
I'm here.
Sorry.
Can you hear me?
Yes, we can hear
Hello,
you.
I can hear you. Can you hear me?
Yes, we can hear you. But Mr. Pradeep was about answering. So after he answers, you can go, please, if you don't mind. Is that okay? Sorry, Mr. Pradeep, can you go on, please?
Yeah, sure. Like I just like to take some of the fact that in 1991, Nepal had neonatal mortality rate was 901, and around 73% of the neonatal mortality rate was declined during the phase of 2020. This data shows that we have but Nepal had made significantly progress toward the preventing the death of mothers during the labor and after childbirth, and Nepal had made a SDG target to reduce the neonatal mortality rate around 70, but this fact, this figure is not going to be achieved. There are certainly we do have invaluable facts and research in this area, but the number of mortality is not remarkably decreasing. And I think one of the major reason is toward this is gender inequality is the major contributor toward this number. We are talking about, we are advocating about the gender equality, but in practice we are not implementing these things. Like we can see that in leadership position or at the decision level, male is dominant to make the decision. In this condition, and the economy of the economy is solely controlled by the male. This cultural perspective or this universal fact leads to the gender inequality and the inequality in service utilization by female. Just one thing, Nepal had almost 73% of institutional delivery, but people living below the poverty line, there is only 19% of the institutional delivery. That make we do have the interesting fact, we do have the resource, we do have proof of concept, but at the implementing level, we are just making the decisions with the head of male dominance. That's one major that's the one major fact from which we are not going to reduce the maternal mortality and causality
Thank you
in
very much.
limit resource setting. Thank you.
Thank you, Mr. Pradip. It's interesting that, I would say that you are a man for women, or what, how do they put it, men for women? So, if I understand right, one of the major ways that we can begin to bridge the gap between policymakers on one hand and clinical researchers and clinicians or practitioners is to have more female representation, because naturally women would begin to champion, the how do we say it? You begin to champion the issues that touch women more, and then maybe it will cause policymakers to listen. Thank you very much for that point. Dr. Salau, over to you. Dr. Salau.
Hello, can you hear me?
Yes, we can.
Oh, okay, thank you. Please, I didn't get the question.
Yes, I said from looking at the case study of Ondo State,
Really
how do we begin to
having a lot
bridge
of
the gap?
network issues.
Yes, sorry about that. I was just
Yeah.
trying to say that how do we begin to bridge the gap between policymakers and
Okay.
clinicians and researchers? You, for instance, you are the head of department in your department at Aisha Buhari Child and Mother and Child Hospital, and you are aware of these challenges. You have seen some case studies of success that were successfully implemented. So, how do you bridge the gap to reach the policymakers, who are the ones that make the policies, to begin to ensure that these things are effected? Or at your own level, how are you able to, implement policies in the community, to bring down maternal mortality?
Thank you so much for that question. At my own level, and considering the community where I work, what we have tried to do is to engage with the community heads around the locality to educate them on these common causes of maternal mortality, and to make them realize that there are proven interventions which can go a long way in reducing the scourge of maternal morbidity and mortality. And we've seen a significant improvement in the utilization of our facility from this engagement. But on the larger scale, it is important that we continue to strive to have periodic engagements between the professionals and the policymakers, because there's almost nothing that you want to do that you won't require the political will from the political class to achieve. So, for example, in Quara, for example, one of the things that I personally always advocate for is for us to have periodic health summits where we can bring all the people involved in decision making. We'll be able to talk truth to them and make them realize what the root causes of some of these problems are. And that way, we'll be able to fashion out a form of
It seems we lost Dr. Salau again. So I believe he's just talking about the need for that collaboration and ongoing relation with policymakers, where we have, gatherings or summits where they can be made aware of the, challenges in terms of trying to translate evidence into practice and, of course, into policy. Thank you very much. I think we'll just ask one or two more questions and then we turn it over to the audience. I know that we have quite a number of experts on this call, and it would be great to learn from your experiences, how you have been able to, um, you know, do something to bridge the gap to reduce maternal mortality. So, another recurring theme that our speakers today have talked about is that cultural aspect of healthcare. The man is the one that makes the decision. Family dynamics, culture, religion, these are things that are very important. But how can we work with these things to ensure that we still reduce maternal mortality? So I would throw the question to, um, I don't know if Dr. Salau is here, so he would just talk about it and then we go to Mr. Pradip. How do we work around the cultural and religion dynamics to ensure that women get the care they need as they need them? How do we involve the males, since they are, the decision makers in many contexts? And how do we engage in health promotion? And also for people even to be able to pick signs of complications, I would say. Because sometimes on social media people have answers for everything. You see a pregnant woman that maybe her leg is swelling, some people will say maybe she wants to have twins. There are all sorts of cultural, I don't know what the word is, things that explain signs and symptoms. So how do we reach the women, even the people around them, to be able to identify danger signs that can potentially lead to increased morbidity and mortality? And how can we also involve the males as the decision makers? In your experiences, what are the strategies that you believe can work for these things? Dr. Salau.
All right. Apologies again for the network challenges.
It's
I
okay.
hope I'm audible now.
Yes, we can hear you.
Thank you. So, the African society is a patriarchal society where most of the decision making is usually taken by the men in the house. In fact, in some instances, like I said earlier, it goes beyond just the male in the house. They take it a notch further to the head of the clan, who usually is the man. So it's important that we continue to advocate. In the past, I used to do a lot of advocacy in the religious houses. Sometimes when you take this information to them in those environments and you let them realize that you're also a religious person, and that does not preclude you from allowing the women to be able to access quality medical care when the need arises. So showing them that you are part of them, you are one of them, go a long way in ensuring a change in attitude in these men. And we can also use all the various media platforms that we have now with the advent of social media. We can use social media to drive um, some of these messages. Or we can create content that will push out there. The more people see it, the more they interact with it, the more they get to understand that women empowerment is something that must be taken seriously. Because a woman that is empowered is not likely going to sit back at home and just wait until complication arises from pregnancy. So I think it's just advocacy and advocacy and advocacy. And it should be a collaborative thing with the religious heads, the community heads, and even governments and everybody in general should continue to advocate for this.
Thank you very much. Mr. Pradip, can you please answer the question?
Beside the affordable and accessible quality healthcare service, we have to integrate the community mobilization and community education program to avoid the people for the utilization of the health service during obstructive care. And while mobilizing the community actor, we have to integrate the traditional leaders, local leaders, as well as the education health workers who are actively involved in the community, who can reach out the each individual house or each individual household to counsel there about the complications regarding the delayed health seeking behavior and the complication of obstructive care, as well as we have to integrate the family planning service and postpartum care. These two are mostly effective, mostly integral, and we have to integrate the male partner in family planning service as well. During that, from that time, he will also be involved in postpartum care. And one another part, we have to integrate the traditional skilled health worker into the formal healthcare sector, which leads to change in their traditional beliefs to utilize the health service from the health facilities. That will obviously change the mindset of the family as well as the male partner, which ultimately leads to the utilization of antenatal care service in the community.
Thank you
Thank you.
very much, Mr. Pradeep. I'm going to ask, you already answered, so I would ask Dr. Salau as well. I know, for instance, if I was, asked that regarding maternal care, looking at antenatal care, care intrapartum and postpartum care, that what is one thing that I would like to change? I personally would like to advocate for a more comprehensive postpartum care for women. For instance, I've experienced healthcare in a few African countries, and I understand that it's largely the same. Where when a woman has a baby, you have the baby, they observe you. If you're fine, you go home. In Nigeria, I understand that I think at 6 weeks you're invited back for maybe a checkup. Am I right, Dr. Salau? That at 6 weeks you have a hospital appointment, right? And but in other countries, you don't have an appointment. They just expect you to come if there's a problem. And I think there's an inherent problem with that because it's not everyone that is trained to see signs of a problem. So I would personally like to advocate, for a more comprehensive postpartum care, or I would say, postpartum care. And for instance, in the West, you go in, I think, maybe a week after, you go 2 weeks after, you go a month after, and not just you, the baby as well is being monitored. Is the baby gaining weight? Are you lactating well? Are there any signs of maybe postpartum depression? Are you bleeding? So many things that could have been picked. There are people that maybe they developed infection and it became really bad. But if there was closer care, I believe that these things would have been picked earlier. So that leads me to my last question for Dr. Salau. Mr. Pradip has answered about integrating community health workers, advocacy at community level. So if you could be face to face with the governor of Kwara State, or should we say maybe the president, what one policy based on your experience from practice and also from research, what one policy regarding maternal care would you push for that should be implemented?
All right. Thank you so much. That's a very, very wonderful question. If I have one opportunity to change something about healthcare as regard maternal health, one
Yes.
thing that stands out for me is to abolish out-of-pocket payments for healthcare services. It's a major hindrance to our women um, getting the kind of quality care they require. You'll be surprised that in some instances, when women come, it's at that point that they need to go and buy just clothes to get examined. It can be that bad sometimes. But if we have an integrated system whereby we strengthen our health insurance system, there are a lot of policy in that direction, but see, implementation and the political will is usually the problem. So if we're able to strengthen it so that every individual and every potential mother has access to a form of health care insurance that covers for antenatal care and delivery services, I think it will go a long way in improving the maternal mortality indices that we have in this environment. Thank you.
Thank you very much. So I think I will just at this point throw it open to our learned audience if anyone wants to share with us their experiences. But I think I will start first from Dr. Drisa. He's the chairman of board of FIRAT and is also an expert in maternal and child health, to share with us maybe a case study of maybe an intervention that was successfully implemented and reduced maternal mortality, and how you think we can bridge the gap between policy and practice.
That's surprising to me. Thank you for for putting me on the spot.
Apologies.
And I really enjoy our two speakers. That was a really awesome presentation, and then getting to the nerve of something. And looking back to some of the question, and thank you so much, Salawu, for discussing the 3 delay. I like that aspect, and I always teach my students to learn that, because that's where everything step in. In developing a developed country, we have that point, which is sometimes we keep neglecting, and then that's where all the problem in maternal and child health, morbidity and morbidity fit in. And looking at what can we do in a community level and also in a system level is a huge thing in between these 3 delays. And I like the aspect of introducing community health worker, which we talk about. Even in the United States here, they play a huge role in connecting health system and community, especially the respective communities that are beyond and that are part of, because of the community listen to them and they know the problem and the culture and the socio-economic factor of the community. They are the one who's the liaison between the health system and the community. They play a huge role. And I did a need assessment here regarding community health worker role in maternal and child health. It was a huge finding. We had it. And then probably later on in one of our discussion, we can go through the finding we find. And I think it's similar to the same thing we are getting in developing country, also in LMIC. And saying that the policy level is something, I like the examples they give. How do we connect policymaker to the system? And we need to have a people who has a knowledge, and then we need to have a people who can really make that connection. Because other people can do whatever and say whatever they want to do. If policymakers are not involved in all whatever we are doing, it doesn't make sense. That's the reason when I'm developing a program, I make sure policymakers are part of it. If they are not, I'm not going to be part of it also. And here they have some great funding, and even you are applying for those fundings, they want to see which policymaker locally is involved on the intervention you are trying to develop. It makes a huge difference, because there are the one who can take it to the next level. We can do the research, we can jump, we can do whatever we want. If it doesn't get to the level which the change can make, it's not going to make any sense. And I really applaud you for providing all this information. I think we are going to go back. And then one of the things I want to ask our speaker is about the technology use, because we are in the world now, And what role does technology like a mobile health tool and telemedicine play in bridging gap in maternal health services in the LMNC? Because this is something, and I don't know if you have any experience with that, that will be really something to trigger. And one thing also is I want to emphasize also is the advice will you give to young professional being a academician. I want to see how can they be involved and advocate for the passion they have about maternal and child health in LMC. They need to play a huge role on that, young professional. I want to hear your little aspect about it. I know we have running out of time, but it's going to be very, very important since we have some of them are still young in the field, and then they want to learn how can they be involved also. Thank you.
Thank you very much for the, I put you on the spot, but thank you for responding. It was very insightful, and also for opening up the questions. You know, Mr. Pradeep mentioned that they use drones to transport oxytocin from the cold chain. I don't know if maybe there are other, you know, technology-based interventions that you have put in place. Mr. Pradeep, can you share with us?
Yeah, I'll just give a small piece of work which we are implementing. We do have the 7 outreach clinics. Our organization is operating 7 outreach clinics in the hard-to-reach area of the country, and where auxiliary health worker or community health worker, they just use during the antenatal care. Those community health workers, they just do the ultrasound in their capacity, and the image will be forwarded in our central
Sorry, Mr. Pradeep, we lost you.
consultation through.
Okay. Please go ahead.
They will just give the consultation from the video conferencing, and if there is the complication in ultrasound, then they will advise to take care about the available nearest available quality available health facility where the safe surgical service is also available. That's our approach, and is quite workable in our setting.
So telemedicine, that's
Yeah.
interesting to see it implemented. Dr. Salau, what experience do you have with use of IT and related tools to reduce maternal mortality?
All right. Thank you very much. Telemedicine is something that has to be embraced by everybody in this age and time. And in Nigeria is not an exception. It's just that the peculiarity we have here is that the private sector seems to be the ones driving this change. We have a lot of applications now that women can download on their phones,
Yeah.
that help them to keep up with their appointments. And when they have complications, they can get a healthcare practitioner to speak with over those such platforms. And many a times they get advice. They can get the nearest healthcare facilities that is within reach that they can visit to get further help if need be. But of course, cost is still a barrier to some of these things. And though the private setting has embraced this use of telemedicine, most of our government hospitals are still lagging behind. And we hope that with time we'll be able to have a comprehensive system whereby even the public facilities can come on board to benefit from telemedicine, because we have a lot of challenge with the number of healthcare personnel. So for us to be able to cover all the nooks and cranny of the country, we need to embrace telemedicine to help us with that.
Absolutely. I agree with you. We are we don't want to go overboard with time. So we just want to say a big thank you to our panelists for today, Mr. Pradeep and Dr. Salau. It's been an insightful time. There are still so many questions, but we cannot effectively tackle everything maternal mortality in one day, which is why it's a series, and we still have another installment where we'll continue to have these conversations. So everyone, we want to say thank you. Don't go yet. We want to say thank you for joining us. If you have questions, now is the time to ask. Our panelists are still here, so please, you can put it in the chat or you can unmute to speak. Or if you want to share an experience with us in 1 minute, you can unmute to share with us as well.
Hi, good evening, everybody, or
Good
good morning, or
evening.
good afternoon, wherever you are. Um,
Thank you.
I really thank the panelists. Thank you so much for the extensive discussion so far on maternal mortality, and all the innovations that you have implemented in your own space up till now. Thank you so much. It feels like it's a lot of men in women's corners, so thank you. I just wanted to. I did do. My background is nursing. At the moment I'm a training advanced clinical practitioner. My concern my concern is are there innovations towards developing like an algorithm led service in maternal health? Because I understand that for the say for an example for the resuscitation council, there are algorithms that you use to tackle problems, and this is because of obviously impacts on health and people's response and preparedness towards emergencies. I believe that if we do develop some of these algorithms, it may have the potential to rescue life. That's one. And then the other thing I wanted to say about translating evidence into practice is that there is the space of making everyone a stakeholder, an economic stakeholder. And I'll give a light example of when I used to work with a particular employer. If I used to have to wake up so early, it didn't matter if I was pregnant or not and had to get to work. I believe that when you explain the impact of that on productivity and the impact on the economic space for an employer, there might be an avenue to develop incentives for having women who get pregnant come out of pregnancy and are fine afterwards towards various employers. So there's that space of making everyone a stakeholder in this matter. So I think there's that little gap between the knowledge, evidence, and translating it to economic value for everyone. Thank you.
Thank you very much for that question and for the contribution, of course. Dr. Salau, do you want to answer the question? Okay, while we are waiting for Dr. Salau, Zainab Ahmad, I'm sorry, I can't see the full name, mentioned that she wants to bring about women organizations enrollment to key in playing a role in this. This is absolutely important. We need women organization, even men
Can you hear me now?
organization to be
Thank you so much,
involved.
Corridor,
Yes, we can hear
for
you.
the contribution.
Please go ahead. Dr. Salau.
In terms of developing algorithms, I want to say, yes, I'm speaking. Can you hear me?
Yes, we can.
Yes, I'm speaking. Can you hear me?
Yes, we can hear you,
Well, if you
Doctor.
can hear me,
Please go ahead.
in terms of developing algorithms, unlike in neonatal, so unlike in neonatal care where you have a common pathway, sometimes it might be difficult to have algorithm for maternal emergencies, but rather emergencies. And many of our delivery rooms have some of these things on the wall. Hypertensive emergency, when you come in, is there protein in your urine? If there's protein, you need to give magnesium sulfate, things like that. So yes, protocols are very, very essential in the management of many of these complications of pregnancy, and it should be something that should be adopted by all delivery units across the country.
Thank you so much.
I think that
Thank
answers
you
the
so
question.
much. So I just want to say thank you to everyone for joining, especially to Mr. Pradeep from Nepal and Dr. Salahu from Nigeria. Thank you to Prof. Jisa for your insightful contributions. Thank you, Koride. Thank you. I believe I saw Professor Olubi on the call. Thank you so much. So we'll be having the next installment next month, and we'll continue the discussions with another set of panelists. But like Koride mentioned, and I think it's very important, we shouldn't limit the advocacy just to the community or even to policymakers. The advocacy has to go to employers, has to go to basically everyone. Everyone has to be a partner in the fight to drive down maternal mortality. And one thing that I would just like to say as a closing is that I believe we have several researchers here, is that when we do research, we should also try to make the effort to reach policymakers. There's this interesting thing that I believe many funders and UK organizations are implementing, which is called lay summary. That when you do research, you're supposed to write a lay summary that a layman can read and understand that, okay, I did this study regarding maternal mortality, and this is what it says in very simple terms. And I believe when people know this, they will be able to hold maybe their local government councillors or mayors or whatever accountable. And this will be the beginning of intense translation of, research and practice into policy. So a big thank you once again to everyone. Thank you so much. And please, if you didn't register, please go ahead and register so that you can have access to the recordings and also to be able to receive emails from us regarding future offerings of this webinar. So thank you once again, and do have a lovely evening. That's all for me. I don't know if there's any other business. But thank you very much. If you want to chat, you can, of course, stay back. But everyone, thank you so much.
Thank you for having me.
Thank
Dr.
you so
Mr.
much.
Pradeep, thank you for being on this panel.
Thank you.
Thank you.
Thank you so much.
Thank you. Have a good day.
You.
Bye-bye.
Thank you. I believe it's very late there in Nepal, Mr.
Bye.
Yeah. Thank you.
Sorry. Have a lovely night.
All right.
Thank you, Professor Jusa. Thank you so much.
Thank you.